2.5 years ago, I was walking through the Calais refugee camp just 2 hours from where we're standing right now. And as I was walking on this rainy day, this day that was miserable and cold, past tents and caravans and hastily pulled tarps trying to protect the inhabitants, the thousands of people taking refuge there every day, I came across this sign. And this sign, as a nurse and a midwife, breaks my heart. This is a representation of what the world sees women in conflict, particularly our reproductive health rights. They're being trampled on, washed away, erased. Currently, there are about 70 million people displaced across the world right now, and half of those are women and girls. Their risk to their lives, their safety, and their health, just because they are women and girls, goes up exponentially in conflict. My name's Rebecca Bartlett, and I founded Shifra with a vision that all women should have access to safe, equitable, and quality sexual and reproductive health services, regardless of the setting. Shifra provides users with quality sexual and reproductive health information in their local language. We're currently available in Arabic and English, and we plan to replicate into Dari next. We believe at Shifra that for women to count, they need to be counted. That's why we use our localised anonymous data to work with local health networks to improve and localise their SRH services for their communities. We know that women in local regions have specific needs based on their cultural and linguistic backgrounds, as well as their level of health and actual literacy. We help to reduce cost and increase the fact that women and girls will not only access services, but will limit resource wastage. Our business model at the moment is working with our partners, who are also our customers. Currently, we are looking at working with different researchers at Monash University in Melbourne. We have cost-sharing models working with local health services. And we also obviously have the opportunity of sharing our anonymous data at a more global level. Our exit strategy is to share our open source platform with the world and see Shifra go global. Shifra is different. We work with refugees, and currently the only people to work on and get paid for Shifra are people with refugee backgrounds. We co-design everything from scratch. Our team is diverse, and we represent a number of countries, multiple languages, and over 5 different industries. Our partners are diverse. To scale, Shifra plans to work with high-income countries with stable and strong health infrastructure, but with high populations of new arrivals, before moving on to long-term refugee settings like Lebanon and Jordan, and eventually work in protracted conflict zones with high levels of local internal displacement. To invest in sexual and reproductive health not just saves millions of lives, it saves billions of dollars. For too long, women and girls have been sidelined from conflict, and as a result, they're not represented in the numbers. You can help us represent them in this data, and we thank you.
Oh, do you have any voice recognition feature? You have many people who can't write and read.
So we don't have voice recognition. What we do is we curate and we create video content for our low literate communities, and we translate what's not already available in local dialects.
How many users are there?
So we launched our first version about 9 months ago, and we have about 1,000 organic users. We've only just released on a more structured scale this week because we wanted to wait until the Arabic had been appropriately certified by local qualified translators. So in this last week, I couldn't tell you.
Yeah, so thank you for the presentation. What's your biggest obstacle right now?
I would say people beyond understanding that women have rights in conflict, funding, because everyone, as I said, works as a volunteer, including myself. So this is our second or third job, and it just means that everything goes slower.
So I understand that you give access to information. How do you actually make sure that the advice is going to be executed in the end? Because how do you make sure that there is a link between the platform and the actual medical?
Right. So whether or not users are going on to engage with services.
Yes, and including pills or whatever you're giving to them. How do they?
So
we're not actually
we're not providing medical services. We're providing the information to connect. So looking at user engagement rates, looking at how we have a mapping feature, so whether they choose to go on and look for a local service, as well as whether they share that information on social media, because that is actually our biggest gauge of whether they trust the information, is whether they're sharing it with other people.
Thank you for the presentation. I'm thinking about the refugee camp and also the work volunteers are doing. Is there an emergency button or anything that would help people? Because we know right now that there's a lot of sexual harassment in those camps happening. We have this record from our volunteers, and I'd like to know if there any solution where they could get some psychosocial support on that, and also some emergency medical something that could help them directly.
So our end goal is to build the health literacy of women. We can't necessarily guarantee that we can connect them to a local sexual violence support worker or medical services unless we have those partners on the ground. So we are connecting them to that information. We can't actually be the provider of those services as well.
Very much.
Thank you.